1. Okay, are you guys able to see?
No, it's just your face.
Yeah, I saw nothing.
You might have to click the button that says present now, because a lot of my other teachers did that and they were able to share their screen. But that was just that. So
Were they using Screencastify?
I have no idea. I don't think
Oh,
so.
you're talking about in Google Meet. So maybe that's the problem, is that.
Yeah.
Okay. That, I think you're right, because I was in Screencastify instead of Google Meet when I did that. Okay. All right, can you see it now?
Yes.
Yeah.
Okay. Good. Okay, and it should be recording. Okay, so if you can't see it at this point, shoot me a text message, but I think we are good to go now. Anyone having any issues, speak up now. Okay. So as I started to say before, I want to do a final review, kind of closing up our EKG curriculum. That doesn't mean that we're done in terms of studying or preparing for that certification exam, but this is kind of pulling all those rhythms together into one slideshow so that we can compare those a little bit. I put together that little matching game that you can print off, or if you're unable to print it, let me know, and I'm going to have the Wilson Talent Center print them and then send them out to students who need them. But basically, you can just print those off and you can use them to make note cards for flashcards types of things, or print off all those rhythms and try and match them with the right label. Just another tool that I thought maybe you could use. Of course, you can go make note cards on your own, or you can even go into make digital flashcards. I know a lot of people like to do that through Quizlet and that kind of thing. And then you could always make some Kahoots. But I think right now, if you guys keep studying and doing the end of chapter review questions, the modules in NHA, and then you are making good, honest attempts towards your NHA practice test, I think you can expect that you'll be able to get that 80%. So let's go ahead and get started here. What I'm going to be doing today is going over some of the vocabulary that we've talked about throughout this, and some vocabulary that I think people are kind of unclear on just based on some questions that I've had. We're going to look at the 3 different types of monitoring, look at the different lead placements, and then overall, we're going to differentiate between sinus, atrial, ventricular, junctional, and heart block rhythms, and kind of figure out how to differentiate between those. All right, some of the vocabulary that I think we need to clarify. These first 2 here are ectomorph and endomorph, and that is just talking about body size. And if you look in your textbook towards the back and it's talking about different lead placements, they just have them set up in a little bit of a different way depending on if someone is very, very thin or someone is larger. Okay, so ectomorph is that smaller, thin, less shapely type of body frame, and then the endomorph is a fuller figured, curvier, more adipose tissue on the chest, especially the chest or abdomen. And then a monomorph just means like a athletic or a neither ecto or endomorph. So there are some differences with lead placement, and that's all you really need to know with that. Again, I want to talk about leads versus, electrodes. So leads are the views that we're seeing of the heart. So when we say we're doing a 12 lead EKG, it doesn't mean that there's 12 wires hooked up. In fact, with a 12 lead, we only have 10 wires hooked up to the patient. Those wires we call electrodes. the pads with the conductive gel that are stickers that go on the patient to hook the electrodes to. Usually they'll call those like electroconductive patches or lead stickers or something like that. But the leads are just what the electrodes are producing in terms of how we view the heart. For example, when we are talking about lead 2, which is typically how we read an EKG strip at this point, it is an inferior view. So because of the way that the electrodes are put on the patient, it's giving us a picture of the electrical activity from underneath the heart. So if we talk about the Einthoven's triangle, it's just the conduction pathway, like the camera view of looking upward towards the heart. So when they say leads, it's not those wires that we put on the patient. And you will hear even in the hospital people calling those electrodes leads, and it's used incorrectly all the time. But in terms of the test, leads are how we get a picture of the heart from the way that the electrodes are arranged. All right, now rounded, peaked, retrograde, that is usually what we use to describe the P wave from the atria. Okay, rounded is what we want. Peaked, of course, is more mountaintop shaped. That's not necessarily a good thing when it comes to a P wave, but retrograde just means negative depiction of that P wave. So the P wave would be like upside down or looked at negatively. If you are seeing a P wave that's upside down in lead 2, there is a conduction problem. And sometimes that can be from the result of a heart attack near the atria, from that coronary vessel, or there's other things that can cause that. But if you see the word retrograde, it just means negative or upside down. And I noticed when I was reading through the book, when they're talking about P waves, sometimes they will say negative depiction and sometimes they will say retrograde. And it looks like they don't use those consistently. They're kind of all over the place, but I wanted you to be able to know what retrograde means. Mid-clavicular, sternal border, and mid-axillary, that's in terms of lead placement. So I wanted to make sure that you're clear, on where those were. So mid-clavicular, it means on the left or the right side you could find this, but it's midway on your clavicle or collarbone. So it would be that line from the midway of your collarbone down your abdomen. Okay, sternal border, your sternum is your breastbone. So the sternal border is where your ribs connect to your sternum. Okay, and then mid-axillary, axillary is armpit. So that would be looking at the chest from a side view and going down from the middle of the armpit down straightward on the abdomen. That's mid-axillary in terms of where you're going to put those electrode patches or stickers. Atrial and ventricular, we're just talking about the two portions of the heart pump, the P wave and the QRS, and I think most people are familiar with that. Duration versus amplitude. So duration, we'll talk about that a little bit more, but that is how fast things are going across the EKG strip, or how fast that conduction is going through the heart. And on an EKG or a telemetry rhythm strip, we're talking about that in terms of seconds. Okay, amplitude is how high or how much power that conduction has. So you might have a small QRS or small P or one that's much, much taller, but amplitude is height. Multifocal, you're going to hear that word in terms of some different rhythms, and that just means it's from different foci or different areas of concentration. And then escape, that's another term you will hear with rhythms, and I'm going to talk to you a little bit more about that. But in summary right now, just in brief, that just means that the rhythm kind of got away from itself and then came back. All right, any questions so far? Okay. The 3 different types of heart monitoring. This is a review. The Holter monitor is also called the ambulatory heart monitoring system because the patient can wear it home. Okay, an EKG is a quick snapshot, just like a quick picture of what the heart was doing at one specific second. And then telemetry is like a video, so it's ongoing, and the patient can be on that continuously 24 hours a day for as many days as we want. So it's like an ongoing video of what the heart is doing with different activities, and we're checking to see if there's any changes over time with that. That would be what we use when the patient's admitted to the hospital, but they might also have an EKG when they're in the hospital, like if the anesthesiologist wants an EKG before the patient goes to surgery to make sure that their rhythm looks good before they put them under. All right, Holter monitoring, it's typically set up with a 5-lead system. And of course, we know that these are the electrodes. Now, we are looking at the heart with 5 different viewpoints around the heart, but coincidentally, when you have a Holter, it also uses 5 electrodes. We call that 5-lead. It's called ambulatory because ambulatory literally means walking, or they can go home. Ambulatory care settings would be like urgent care, the doctor's office. Those are places you don't stay, you go home. So ambulatory just means they can wear it home. Typically, it's done over 24 hours if the patient's been complaining of chest pain, or we know that's called angina, or they've had pain with exercise, they are a high-risk candidate for a heart attack or something, then they would monitor them for 24 hours at home, just doing regular activity. All right, the EKG is the quick snapshot of what we would look at with the rhythm. Now, I want to point something out to you because this picture looks much different than what we've looked at with just our rhythm strip that shows just one picture. So when we use a machine like this, like we had in the classroom, and we put all 10 electrodes on the patient to do a 12-lead EKG, this is what we would print off. And it looks crazy, and it's so much, and it's totally confusing. And you can see some of these QRSs are upside down, and some of the T waves are upside down. And that's because this is all 12 leads being put together at once on one piece of paper. So you would print it off, and the anesthesiologist or the cardiologist or whatever type of physician is going to compare these different leads. So basically, it is a collage of all the leads together printed on one piece of paper. And if you look closely right here, this picture is kind of blurry, but lead 2 is typically printed at the bottom across the whole bottom. So here's your lead 2 strip. And of course you can't tell, but it says lead 2 right there. It's kind of blurry. These are the other 12 leads. So here's lead 1, lead 2, lead 3, and then AVR, AVL, AVF, V1, V2, V3, V4, V5, V6. So right here is all 12 leads printed together so that they can compare that, because sometimes looking at the heart in a different view gives them even more insight as to what might be going on. Okay, but typically they're going to look here first, because this little section right here is a couple beats of lead 2, and then lead 2 all the way across the bottom. Now, because this is a 12-lead EKG, we're going to have all of those. If we go on to telemetry right here, the one that's like ongoing video, here is a picture of what the monitor would look like at the nurse's station. Here is a picture of the box that the patient would wear. We had gowns with pockets in them, but this patient's wearing like an external pocket for that telemetry box. And she's all hooked up to these leads, and typically we hook up 5 electrodes to get this, but this is what the rhythm strip would look like from telemetry. So there, it looks like there's 8 or 10 patients all being recorded on this, if we wanted to print it off instead of just having it going continuously across the screen, you can print it off on the telemetry paper right here. And then this is what gets printed off. And that is in lead 2. And that's typically what you are going to see on your exam, or as I'm teaching you about the rhythms right here. So typically you're going to see one view of the heart that you're going to read. I said normally we have 5 leads, but sometimes they can use 3 electrodes to get the 5 leads. Okay, and then I've got a little short video for you guys.
Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video, I'm going to demonstrate for you how to place electrodes for a 5-lead telemetry monitor. Now, in the hospital, a physician may order a patient to be a telemetry status where they will wear a telemetry box during the whole hospitalization, and their heart rate and rhythm will be monitored by a telemetry unit. The boxes vary in size. They can be relatively big or small depending on the type of supplies that your hospital bought. And there's 5 connections that will go on the chest, and they have different colors. And those colors really throw people off. So here in a second, I'm going to give you a great way on how to memorize those colors. And I'm going to show you exactly where those little stickers go on the chest. Now, before you place a monitor on a patient for a telemetry monitor, you'll first want to prep the skin properly, because if you don't prep the skin properly, you may get a really bad connection. So this is the supplies you will need in order to prep the chest. You will need some alcohol prep, which will just remove any oils or dirt from the skin. You'll need some exfoliation paper. I call it sandpaper. It just roughs up the top layer of the skin so you get a good connection with your electrode. And then you'll need a packet of electrodes. Always make sure your electrodes have not expired and that the gel, which is behind this little sticky part on the electrode, is nice and moist. You don't want any dry electrodes, because if you do, you'll get a lot of artifacts and they won't stick to the skin. So let me show you how to place these electrodes. Okay, you'll want to expose the chest, and you'll get your telemetry box, you'll put the battery in the box, and you'll get your sites ready to put your little electrode stickers. Now, on the back of each electrode is a little backing that you'll have to peel off, like that. And first, I like to start over here on the right side. What you have first on your right side is your right arm lead and your right lower leg lead. And this will be white and green. How I like to remember that is snow, which is white, over grass. So your right arm lead will go in the second intercostal space of the ribs, so about right in this area. And how you want to prep the skin is you want to take your alcohol prep and you just want to clean the skin really good, get those oils off, and then lightly take your exfoliation paper and just scratch on the area lightly just to rough it up, and then peel the backing off of your electrode and place it on the skin. And make sure you put it down really well. And next you'll do your left arm lead, and this is the green, like we said, and it is down here right below the lower edge of the rib cage, which is right here on this mannequin. And it's on the non-muscular area, so you don't want to put it over the abdominal muscles. So you'll do the same type of prep. You'll clean with alcohol, and you'll lightly scratch, and then you'll put your electrode on. So we have right arm, right leg, and we have snow over grass. And then let's do our left arm leads. We have left arm and lower leg. So what we'll do is we'll prep for that. And remember, watch out for any pacemakers, implanted devices. You can sometimes have sub-Q ports or even pacemakers over here, and you never want to put your electrode over that. So you'll want to go away from that. So you'll clean the skin right here. It's a second intercostal space on the left side of the body. It's literally right across from your right arm lead. And you'll just take your backing off, put it on, second intercostal space, and this is the black lead, okay? And this is going to be our left lower leg, and this is going to be the red lead, so you have smoke over fire. So clean that area, and this is literally right across from your right leg lead, and it's on the lower part of where the rib cage is, on the non-muscular area. And we have one more left, and this will be V1. V1 is the brown lead. And everyone just tries to remember this as chocolate in the middle. So the brown lead will be at the fourth intercostal space, which will be right in this area. Clean your area, prep it, and then put your electrode on. And you are done. And then you'll connect your wires. So let's go over it again. You have snow over grass, smoke over fire, and then chocolate in the middle. So you'll connect your electrodes to this. You'll immediately then call the telemetry unit for your hospital. Make sure they are picking up the patient, that they're getting a nice, clear EKG, the batteries are working that you put in, and that they have the right patient information, because you never want, because if you had a patient in that room and you didn't clear out that information, they might have another patient in there. So always make sure that. And that is how you set up for a 5-lead telemetry monitor. Thank you so much for watching, and be sure to check out my other videos on how to place electrodes for a 12.
Okay, so that is a good demonstration of how to set that up. I use a similar mnemonic when I put on leads or electrodes, and I say clouds over grass, and she said snow over grass, but and then we say brown is ground, which is right in the middle. But however you choose to remember it, that is the 5-lead telemetry setup. All right, a quick little bit of information about duration versus amplitude. Duration is mostly what we're looking at when we're checking out an EKG strip or a telemetry strip, and it is in terms of seconds. So we know that the little boxes are 0.04 seconds, and then there's 5 little boxes, so the one big box is 0.20 seconds. So these EKG calipers are approximately 2 large boxes across, and they are measuring from the beginning of the P to the end of the QRS. And then amplitude, which we don't look at a whole ton, but basically 1 millimeter, which is one of these going up, each one are about 1 millimeter, it is 0.1 millivolts. So that is saying how many millivolts from the very lowest to the very strongest point of that electrical activity. And we don't look a whole lot at amplitude. We're mostly looking at duration. All right. Pacemakers of the heart. This is review for you guys, but we know that we have the SA node, the AV node, the bundle of His, and then they separate to go around both of the ventricles, and we call those the Purkinje fibers. And that is how the electrical conduction flows through the heart. And they do go into the sides of the ventricles and the sides of the atria too, but they highlight usually these main branches, okay? So if rhythms start from the SA node, which is really what we want to get a good double pump, which is what the heart is, and perfuse the body with 60 to 100 beats per minute, which we know is ideal in terms of adequate perfusion or a normal heart rate. If the AV node, or excuse me, the SA node is not working, not behaving, or just asleep, the AV node would take over as the second or the backup natural pacemaker, but it can only do a job of about 40 to 60 beats per minute. Okay, and then if the AV node also isn't working, then the bundle of His and the Purkinje fibers would try and take over as a last-ditch effort to continue to perfuse the body, and they can only do about 20 to 40 beats per minute. So the SA node is like the captain, but if there is no captain falls off the ship or whatever, however you want to think about that, then these secondary nodes will try and take over as the pacemaker, but they can't do as good of a job. Okay, and that is where some of your arrhythmias will come in. All right, atrial and ventricular contraction. We know that the SA node creates the P wave, and that is what is making both atria contract. Okay, ventricular beats are made by the bundle of His and the Purkinje fibers, and that is the QRS complex. Okay, therefore, in between those areas is our AV node right here, which produces the space between the P wave and the QRS. That's the communication between P and when QRS picks up or answers. Okay, we call that the PRI. So that interval, the PR interval, if it takes a really long time for QRS to answer the phone, then we know we have a conduction problem. So the measurement of that PRI between our P wave and the QRS is very important, and that is being caused by the AV node because it's kind of like the messenger at this point. If the SA node is working, the AV node is like the messenger sending the impulse down to the bundle of His and the right and left Purkinje fibers. All right, determining rate. We talked about 3 different ways to do that. If you have an irregular rhythm, they want you to use the 6-second method typically because it allows you to look at several beats at once. But make sure if you're going to use the 6-second method to determine the rate on the exam, make sure you have a real 6-second strip because sometimes they increase or decrease the size of that rhythm so you can see it better. Although I'm hearing that it's still really hard to count those boxes. But make sure you have 30 large boxes if you're going to use that. Okay, so you would count how many P waves or QRS waves, depending on whether you're looking at the atrial or the ventricular rate, and then you would times it by 10. Okay, if you have a 6-second strip and it's irregular. If you have regular rhythms, you can use the 1500 or the 300 method because you should see, if you have a regular rhythm, you should see the same amount of boxes between each complex, and that doesn't change much. So you could use this method, but it is kind of hard to use these 2 methods on an irregular rhythm because between each QRS, you're going to have a different number of smaller, large boxes. So that's why for irregular rhythms, this can be better, but you can use either one. And again, you're just kind of guesstimating. A lot of times the monitor, like on this one right here, it's saying she's got 81 beats per minute and she's perfusing at 98% oxygen and she's got 19 breaths per minute. So typically it's going to show you, but if you print off the rhythm and you're trying to get a quick idea, you would do that. So the 1500 method, and you can review these in your book, it's going to be very important that you know this for the exam. But basically, if you're counting the little teeny tiny boxes, which are 0.04 seconds, you can count how many you have of those teeny tiny boxes and divide it by 1500. And if you're doing the large box method, you would divide it by 300 to get an approximate rate. All right, so step-by-step interpretation, what I want you to always do is use these first 5 steps. Sometimes you have to use these extra 3 steps, but for the most part with rhythms that you guys are identifying, steps 1 through 5 are going to be enough. But I always say start with the rate, and that's going to tell you whether it's Brady or tachy or if it's a normal rate. Then the regularity, is it regular or irregular? And as you go through these steps, you can narrow down what type of a rhythm you have. Then you look at the P wave. That will tell you if the atria are behaving. Then you're going to look at the QRS to see if the ventricles are behaving. And then you're going to see how the conduction is between the 2, which we know is our PR interval or PRI, and we don't want it to be more than 0.20 seconds, or we know that that's a delay in conduction. Okay, then we can look at some of these other things, but they're not quite as important as we go through some of these rhythms. Is everyone doing okay? Does anyone have any questions? I can't see the chat right now. Oh, Anna says, can you add me back in, please? Let me go back.
I'm in already.
Oh, awesome. Okay. All right. This is just a quick overview. You've seen this.
I have a question real quick, sorry.
Yep, go ahead.
I was wondering, when I do the practice tests, I use my calipers because it's too small to try to count the boxes. Can we use that on the actual EKG certification test?
I believe that you can, but I would just be careful because I don't know if they've enlarged it. And so you can still use your calipers to measure it, but I wouldn't suggest once you get a measure or to count it, I'm saying, but you wouldn't want to use it to measure it because they might not be set up with each small box at 1 millimeter.
Okay.
You know what I mean? Like you could
Yeah.
use your calipers to help count, but
Whenever I used them, I always got the question right, but I could never actually count the small box. I would get it wrong every time if I didn't use the calipers because it's too small still.
okay. So they were helpful in terms of pointing exactly to each box.
Yeah, then I could get the exact answer, but when I didn't use them, I had to guess because I couldn't even read it.
Okay. All right. That is what I'm hearing from other students as well. So
Okay.
I believe that you can use those. I can't imagine they would say you can't use EKG calipers on an EKG test, but I'll find out for sure.
Okay.
Okay. So here is the complex you guys have all seen 100 times. This, of course, is a beautiful normal sinus rhythm. The P wave and the Q and the R and the S, and then the T is the repolarization. And it's just showing you where those intervals are. So if you're measuring the PRI or the PR interval, that means the space from the beginning of the P to the beginning of this Q. Okay, so it's like all of the atria, or how long it took the atria to talk to the Q, and when did the Q finally answer from the ventricles. Okay, so if this PRI is super long, that means the conduction from the atria to the ventricles took forever. And the other one that's pretty important for you guys is the QRS complex, because if it's really, really wide, or we know that means a lot of time, then it means the conduction through the ventricles, or from the bundle of His to the Purkinje fibers, by the time the ventricles squeeze, took too long. So that's from the beginning of the Q to the end of the S. Okay, and then they don't have you guys worry too much about how long it takes after that for the ventricles to repolarize. We don't talk a ton about that T wave, but that may become more important as you advance your education and go into nursing or PA or even higher level. You would start to look even further at the rest of these measurements. But for you guys, the PRI interval and the QRS complex is what's going to be most important. So from the beginning of the P to the very end of that interval, which is right where the Q starts, or right when you have the downward deflection off the isoelectric line. And this would be your isoelectric line, kind of the baseline. Okay, and if you're measuring the QRS, it would be from the very start of that to the very end of it. Okay. We're going to run through sinus rhythms. I think that this is probably the easiest area for you guys, but basically this is our A+ gold star. You did perfect. Everything is working just beautifully because it's starting from this sinus node. Okay, so we're going to go through these 6 rhythms here. Normal sinus rhythm, this is our best, our favorite, our ideal, and what we would want to see. So I can kind of see the isoelectric line here, which is the baseline. I can also guesstimate the rate here, and I know that it's a normal sinus rhythm if it's between 60 and 100. This one's pretty easy to count the large and the small boxes, but I would still use my calipers on this one just because it's a little bit blurry. But our rhythm is regular. I wish I had digital calipers so I could show you. I should look up that tool, but everything right here looks like they're evenly spaced. And if you wanted to know for sure, you would use your calipers and bounce those along between each of the complexes, and you would know that that is regular. The P waves are upright and they are rounded. There's a P wave and a QRS, and a P wave and a QRS for each complex. So we know the atria are talking to the ventricles. The QRS, it's not taking too long for the electrical conduction to go through the ventricles. And our PRI is less than 0.20 seconds when we measure that with calipers. So it's not taking too long for the ventricles to answer when the atria call. So that's perfect. That's exactly what we want. Okay. Still coming from the sinus node, but just a little bit slower. So we still have pretty P waves here. We still have a nice QRS complex that's not too wide. Okay, it's just that there's not very many of them. It's less than 60 beats per minute. Okay, so this one's probably about 35 to 40 beats per minute if I guess off the top of my head. Now I see these lines here, so that tells me that this is a 6-second strip. So here's 3 seconds, here's 3 seconds. In these 6 seconds, I see 4 ventricular complexes, and obviously, since it's sinus, I'm going to see 4 atrial complexes. So our rate is 40-ish, okay? Everything else is completely normal. It's just a little bit slow. All right, same thing here. It's sinus because we still have a P wave for each QRS, and the P waves still look good, and the QRSs still look good. There's just more than they should be. Now, this rhythm strip, you can't see exactly where the notches are for every 3 seconds like you typically would have, but you can still count to see that you have 30 large boxes because that equals 6 seconds. Because each large box is 0.20 seconds. Okay, so the rhythm looks completely regular, and I can see there's a P for each QRS. Everything looks good. It's just a little too fast. So maybe someone's having anxiety, or they just did a bunch of jumping jacks or something. All right, sinus arrhythmia. This one can be kind of confusing for people, but basically, if you're taking someone's pulse and you have your fingers right by their radial pulse on their wrist, it will just feel like there's like a little skip in a beat because it's not completely regular. And that's pretty common in pediatric patients for it to be irregular because they never sit still and they're always jumping around, and their body is so young and healthy that it's able to compensate and switch gears really, really quick according to the movement or the oxygen consumption needs of that child. But for an adult, we should see a normal sinus rhythm. And when we have just some irregularity in how often those beats come, we call that sinus arrhythmia, but everything else looks good. It's not like the PRI is super long or it's taking a long time for the ventricles to answer. It's not taking too long for the impulse to go through the ventricles. Okay, it's just a little bit irregular, but each complex looks great. Okay, so when we say block, because we just did our section on blocks, that just means that there is like a roadblock in between something within the heart. So if we have an SA block, that just means that from the SA node, there's a block, okay? But it's still a sinus rhythm because the PRI is still great. The QRS is still great. Okay? The rhythm becomes like blocked right here. Otherwise, the rest of the rhythm is completely regular. Okay? If everything was irregular, we would call it sinus arrhythmia, which was this one. But in this one, everything is regular if you look at the long section of the strip, but there's just like this long pause here. Like there was a little bit of a block from the SA node and it didn't fire and it didn't fire and it didn't fire. And it's like, where are you? And then all of a sudden, oh, there it is. And it came back. So that was just a little bit of a block from the SA node. Like they fell asleep for a second. Not your patient, the SA node. All right. And then sinus arrest is instead of a SA block, if you miss more than one complex, like right here, we can see that that complex probably should have come about right here if we look at the regularity of the rhythm. If you miss more than one of those complexes, like everything's normal, And then you miss, this one's missing about, well, they're saying 88 small boxes or 3.52 seconds. If you can imagine your heart not beating for almost 4 seconds. So they've missed, probably, judging by the width of the underlying rhythm, we're missing 1, 2, probably 3 complexes, and then boom, it comes back up. So it's like they're arrested and then they let them go and everything comes back. So it's just like an essay block where we're missing a complex and everything comes back beautifully. Sinus arrest is really, really long, or more than one complex. Now, if this went on and the essay node didn't tell the atria to pump and we didn't get a P wave, like if nothing came back, we would say that the patient went into cardiac arrest or asystole, because this looks like asystole, but then the SA node wakes back up or gets released. Okay. So that's all of the sinus rhythms. If every QRS complex has a P wave and our PRI and our QRS measurements aren't too long or taking too much time, then you've got a sinus rhythm. Okay, where the problems begin is when one part of the heart stops doing its job. So atrial rhythms are problems with the atria. And I just have this P wave circled right here because that's what we're going to be talking about, is those P waves. How's everyone doing? I know that this is a lot of information. The sinus stuff was more of a review. So now we're going to go over some of the different specific arrhythmias. All right, premature atrial contractions. Basically, the P wave gets so excited, going crazy, and just fires too soon. Okay, and here is the regular underlying complex. Everything looks regular because these complexes are the same width apart, but every once in a while you get a PAC, which you would think if it was stayed normal, the complex would come about right here or right here. And it's like the P wave fires too early, so the ventricles follow suit, but they didn't need to fire that early. Okay, that can just happen because sometimes the SA node is like, oh, do you need me to throw some extra beats in here? Or it anticipates that the rate is going to need to increase, but it doesn't necessarily need to do that. So if you see an underlying rhythm that looks really regular because all the other beats are regular, but then you see something that happens a little bit early, if it has a P wave on that early beat, then you know it's a premature atrial contraction. So there's still a P wave. The PRI is kind of too long on these early beats, but the PRI looks great on all the other ones, and so does the QRS. So it is an irregular rhythm due to the PAC, but the underlying rhythm, when it's behaving, looks completely regular. All right, wandering atrial pacemaker. We know that atrial pacemaker is the SA node. This is just what they call this rhythm, and I'm just breaking down the terminology for you. But the atrial pacemaker is, of course, our captain or the SA node. Okay, if it's a wandering rhythm, it's like the SA node and the AV node are like fighting over who's in charge. So the SA node's like, nope, I know what I need to do here and I've got a job to do. And the AV node is saying, you're not doing a good job. I'm going to take over for you. And they're going back and forth. So what that looks like is the P waves are different. So here the SA node was in charge. Here the SA node was in charge, but look how peaked that P wave is. Then this one, there's either like a retrograde or a deflected P wave, or maybe not even a P wave. Then you get a normal one. Then you get no P wave. And that's when the AV node is completely taken over. So everything looks pretty regular, but maybe a little bit of mild irregularity here because it widens out a little bit. But if you take a look at the P wave when you're looking at the complex, you'll say, oh, they're all different. That means it's wandering between the SA and the AV node. That's all it is. Other than that, the rhythm is going to look pretty good and the rate will be 60 to 100. So if you just start by looking at the rate and then whether it's regular or irregular, and then you look at the P waves, you're going to know that it's wandering between the SA and the AV node. They're fighting. All right, atrial flutter. I put a butterfly on here because that's what I think of whenever I see atrial flutter. We know it's an atrial rhythm because the QRSs look good, but there's a whole bunch of P waves in front of all the QRS complexes, and we know that there should only be one P wave. So it's like the SA node is firing over and over and over and over and over again, and the QRS are only able to keep up with them like every 3 or 4 firings from the SA node. So there's no way that the QRS is able to keep up at this point. And it just reminds me of butterfly wings. Like as soon as I see that, I know that there's some flutter going on, and that's exactly what they call it, atrial flutter. So the rate is usually, if we look at the atrial rate, it's 250 to 350 because we're counting all of these little P waves. The ventricular rate can be variable. It sometimes is a normal 60 to 100 rate, which is right here. But if we have a ton more atrial complexes than we do ventricular complexes, our heart isn't doing a good job of perfusing, and that's the problem. The SA node just, for some reason, keeps firing. And we can't even measure the PRI because the P comes right before the QRS. All right, AFib, I just think about the atria and they're just shaking, like shaky hands. The atrial rate can be 350 to 600 because it's not a real SA beat or a P wave. It's just like all these shaky attempts at P waves, but the QRSs look okay. They're a little bit irregular because they don't know when to fire. But there's a problem with the SA node, so we know it's an atrial rhythm here as we look across. So it's irregular, it's chaotic, it's just fibrillating, or just the atria are just shaking.
I have a quick question about that.
Okay.
So then would you start defibrillating the heart or start CPR if that were to happen?
You wouldn't start CPR unless the patient was unconscious, and what they're going to be feeling at this point is just like their heart is like, they're going to say it feels really weird, and I feel like there's pulsations in my chest, and I'm sweaty, and it's going to make them nervous. So they're going to be a little bit anxious. But basically what they would do is, if it continued and they couldn't get them out of it using medication, they would go in and put in a pacemaker to make.
So say you're doing a 12-lead EKG and someone were to have atrial fibrillation, what would you do at that time? Would you just call for help from a nurse, or?
Well, it's not necessarily emergent at that point. They may have come to the hospital because AFib is really common, and that's usually why people end up with a pacemaker. So it's efficient enough so that they're not unconscious, but they don't have a lot of activity tolerance. So you would let the nurse know, you would take it to them and say, it looks like we've got AFib here. And they'll probably be like, yep, that's why they came in. They're doing a pre-op EKG so that they can have a pacemaker placed or whatever. If it's something brand new, then of course they're going to treat it a little bit more serious at that point. But it is a fixable rhythm once it's identified.
Okay, thank you.
Uh-huh. All right, good questions, guys. Okay, so I like this little picture. I had to put a little heart over the naughty word on there, but I thought it did a good job explaining what's going on with supraventricular tachycardia. So we call this SVT, and I have a little picture of the rhythm here, but basically the complexes are coming so fast that the T wave, or the repolarization of the ventricles, covers up the P wave, or kind of like leaves a notch right here because there's not time before more beats are coming. So it is a ventricular rate that's more than just a regular tachycardia, because a tachycardia is like 100 to 150. And now we are talking about 150 plus beats a minute. And that's when the P and the T wave from the previous complex start to overlap. Okay, so this one's like, whoa, everybody calm down. And I thought he was really cute, little squirrel. And then it just says at the bottom, when the people in the commercial start talking at the end of the commercial, and they're talking like 1,000,000 miles a minute. And that's what's happening with the heart. It's just going crazy. Okay, even if somebody had done some major exercise or they were really anxious, they shouldn't be 150 to 250 beats per minute. There is a problem here with the heart kind of over responding. The QRS can be normal, like in this example, but they can become really, really wide as things worsen or the heart can't compensate anymore. Okay, multifocal. We have this multifocal word again. That means that things keep changing with the atria. Okay, so we had wandering atrial pacemaker. This one is pretty much the same, only it's faster. Okay, so multifocal means it's coming from different areas. And if you look at the P waves here, they are not rounded and beautiful. So we know we've got an atrial problem. So that makes it an atrial rhythm. It's irregular. And again, there's a fight going on between the SA node and the AV node. But the QRS complexes look great. But we can see that there's some irregularity with when they come. But when you see the P waves are all different and they're kind of crazy or not there at all, it's wandering or multifocal. Those words can be used interchangeably. When the AV node takes over, typically we know it can only beat 40 to 60 beats per minute. So the fact that it's able to produce tachycardia with this is meaningful. So we call that multifocal atrial tachycardia. And again, if you start by looking at the P waves and the rate and the regularity, it will tell you that you've got a problem with the atria here. All right, that's it for atrial rhythms. Ventricular rhythms, we're now looking at the QRS. All right, how are we doing on time here? Oh my gosh, it's already 1 o'clock. Well, I can keep going. I don't know what you guys have going on. I would like to get through all of this. But I understand if you guys have other obligations, and typically we try and keep these around an hour, and we had a little bit of technical difficulties in the beginning. What I'm going to do is keep lecturing, and if you need to go, then that's fine. If you want to stay and listen, of course, that would be helpful for you. I'd encourage it, but I am hoping that I can share this screencast so that you can watch it when you have more availability, but I can't make up this lecture any other time this week. I'm completely booked with other calls and things that I've got to get done that we have to turn in for work and all of that. So I don't think that I'll be able to find another time to re-lecture, and I want you guys to have this when you take your EKG practice test today. So I'm going to keep going and see where we're at in about 30 minutes and reevaluate from there. All right, so I'm going to go.
Putting PowerPoint in Google Classroom?
Yes. Yep. I absolutely will. Although I feel like the slides that I make have very little information, and it's mostly me talking to describe those. But of course, it would be better than nothing for you to just have the slideshow. But I think the screen captions will be most helpful. All right, so we are going to go over ventricular rhythms, looking at the QRS. In idioventricular rhythm, excuse me, you can kind of spot that right away because all of a sudden the QRS is super wide and there's no P waves. So we are going to have an absent atrial rate. and the ventricular rate is typically going to be between 20 and 40. So right away when you look at it, there's a serious problem. The atria aren't doing anything, and the ventricles are doing something, but in a very, very slow kind of way because it's super wide. Okay, accelerated idioventricular rhythm is the same thing, only it's 40 to 100. So it's just a little bit faster or more of those ventricular complexes, but no atria activity at all. Okay, this is one of my favorite ones. It's very easy to identify, and I've become really good at identifying VFib. So ventricular fibrillation, we had AFib, which is the atria just fibrillating. And this time the ventricles are doing that. So they're just doing this shaky, shaky stuff. Okay, it's a chaotic rhythm. You can't really measure the PRI or even the QRS because everything's crazy and all over the place. And you really can't even count the rate because they're not actual complexes. So the ventricles are just shaking, and this usually leaves the patient unconscious. They end up having to be defibrillated and possibly a pacemaker if this is something that's frequently happening because there's a problem with the conduction. So VFib is pretty common. It looks a lot like atrial fib, only now it's the ventricles. Okay, a PVC is a premature contraction. So the underlying rhythm would look very regular with a good P wave and a good QRS. And then all of a sudden, you don't have an early P, but you have an early QRS complex that's really, really wide. So it's like all of a sudden, just randomly, the ventricles fire. And then it goes back to its normal beat. So it's, you look at the rhythm and everything looks normal except for these random PVCs. I know it's not an atrial contraction because there's no P wave there. Okay. Ventricular escape beat just is this complex here. The underlying rhythm looks really normal. And then it's like the ventricles just escape and start going really, really fast and really, really crazy without any direction from the atria. So it's a ventricular escape rhythm. And typically you'll see 3 or 4 of these beats, or maybe more, maybe less, but then it goes back to this normal underlying rhythm. So the underlying rhythm would be normal, 60 to 100, with everything looking good. And then all of a sudden, you get these escape beats where the P wave is absent or retrograde. So retrograde means upside down, okay? And they look kind of absent and weird with those escape beats. All right, torsades, that just means it's kind of like ventricular fibrillation, only the rate is able to be measured because the complexes are bigger. On VFib, it's like shake, 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 shake. On this, it's like we're really, really trying, but it's not quite there. So torsades is like the ventricles are trying to do what they can. The rate is 200 to 250. The QRS complexes are typically really, really wide. We know asystole. I wanted to just take a moment to tell you guys that you don't just hook them up and then you see this. Typically, they have a rhythm that is fading and fading and fading, and then results in asystole when they just can't get them back. All right, here's VTAC. I want you to take a look. It looks like torsades, only it's more organized and it looks regular. Torsades is irregular. Okay, so VFib is little tiny, tiny, tiny shaking. Torsades is when there's a little bit more height and you can count the rhythm, but it's chaotic and irregular. VTAC, it looks very, very regular. It looks like sawtooth or like shark teeth to me, and you can easily count that rhythm, and it's higher than 100. Okay, the P waves are completely absent. The QRS is super, super wide in VTAC, and that one's pretty easy to recognize. Okay, moving right along here, we don't have much more to do. Junctional rhythms. What I am thinking of when I imagine junctional rhythms is that the AV node had to take over as the pacemaker because the P was like gone, who knows where, at home sleeping, overslept, didn't hear the alarm clock, who knows what happened. They aren't there. So if you see a rhythm and you're analyzing the rate and the regularity and then the P wave and you're like, oh, there's no P wave at all, but everything else is going on, then you likely have a junctional rhythm. So junctional just means the space between the SA node and the Purkinje fibers. So the rhythm is starting in that junction rather than up at the top in the SA node. All right, these do not start in the SA node, but down further in the conduction system, so there will be no P. Also, without the SA node, we know the rate is generally only going to be able to be 40 to 60 beats per minute. Okay, so I put this little meme here. Because the AV node has to pick up the slack from what the SA node isn't doing, and that puts a lot of stress on the heart. Okay, a PJC, because we've been talking about premature contractions, you're going to see a regular underlying rhythm, and then all of a sudden this premature contraction, which is right here. Okay, and it's like, why are you right there? You should be over here a little bit more. So, oops, I have a typo right there. The rhythm, the underlying rhythm is regular except for that premature beat. The rate is 60 to 100. And this premature beat, see how like these all have a good P wave? Right here, the atria are like, who knows what's going on? And this one's retrograde and it's below the isoelectric line. It should be way up here. And it's upside down. And then all of a sudden, you've got this complex. And notice how this QRS looks different than the rest of these. So that's a PJC. All right, here's a junctional rhythm. The reason it's junctional is because it's not sinus. It looks almost like it could be sinus, except for there's no P wave because the P is at home in bed oversleeping. So the AV node had to take over as the pacemaker, and you're going to have this lower rate of 40 to 60 because the information's coming from the AV node instead of the SA node. Okay, so we've got what? 30 to 40 beats per minute there. Right? Junctional escape, just like in the other escape rhythms, it's like you get a long pause and then things start happening again. Okay, but the P waves are crazy and they're all different. Okay, so you're having these beats, but a little bit of an escape and then it picks back up. I wouldn't call it a block over this length of time. All right, accelerated junctional rhythm. It just means that, yes, that junctional area in the heart around the AV node and the bundle of His is taking over as the pacemaker, but somehow it's able to produce a beat that's in the 40 to 60 range. Okay. And so if it goes higher than 60, we call that accelerated junctional rhythm. It's not tachycardic because it's not over 100, but it's still higher than what you would expect this junctional area to be able to produce. So if it's more than 60 and there's no P wave or evidence that the SA node is working, it's a junctional rhythm that's accelerated. Okay, and then one step beyond that, you can have junctional tachycardia. So somehow that junctional area, that AV node and the Purkinje fibers are somehow getting a rate over 100, and we know that that's always a tachycardia. So when you're analyzing and you're counting the rate, you're like, okay, well, I know it's a tachycardia to start with, and then you go to analyze the P waves, and they're retrograde or negative, upside down. So that means we have a junctional problem because the SA node isn't working. Other than that, it looks regular. The QRSs look pretty good. All right. This is just a slide to show you the premature complexes and how they differ and how you would identify which one they are if they're coming from the atria, the junctional area, or the ventricular area, because it's easy to see a regular rhythm and all of a sudden you see a premature beat, but sometimes trying to determine whether it's atrial, junctional, or ventricular can be confusing. But when you analyze the P wave, like here's a P wave on a premature complex, so we know it's atrial. Here we've got an inverted or absent P wave on a premature complex, so that's junctional. And if it's a premature ventricular contraction, usually you see no P wave and you see a notched QRS, and the QRS is really, really wide and big. All right, we have 4 more to go. It's 1:13. I think I can get it done in another 15 minutes and be done by 1:30. So if you're thinking about whether or not you need to go, I think we'll be done in about 15 minutes. We'll go through this, and this is the one that we just went through. So you're going to see some of the same things, but a little bit more of an overview explanation rather than an introduction. Okay, so heart blocks are like a mouse has cut the wire. Okay, you go to turn on the light switch, the light doesn't come on, and you're like, what happened? Somehow there's a block somewhere in the conduction or the electricity. So there's 4 different types of heart blocks, and they are easy to differentiate if you can remember some of the rules. So here's our heart block poem. If the R is far from P, then you have a first degree. Longer, longer, longer drop, then you have a Wenckebach. If some P's don't get through, then you have a Mobitz 2. If P's and Q's don't agree, then you have a third degree. So I'll break those down. It sounds chaotic and overwhelming. It's not. It's really pretty simple. So first degree heart block, I thought this cartoon was kind of cute because he's like, Mamma mia, I'm late again. So this little delivery guy with his pizzas on his little moped, he's not getting to the QRSs or to his customer on time. And he said, are you sure you ordered the pizza? And then the P wave's like, it's like, or the T wave's like, it's like this every time. He's always behind. So all that's happening in a first degree block is the atria are calling the ventricles and the message doesn't get delivered. So the PRI is more than 0.20 seconds, because we know the PRI should be 0.12 to 0.20 seconds. So if you've got too many small boxes and the atria are taking too long to get to the ventricles, that's a first degree heart block. So a PR interval that takes more than 0.20 seconds. So here's your P wave and then your QRS. It just took too long to get there. That's all. Okay, second degree AV block, Mobitz type 1, or they call it a Wenckebach. Basically, you have the P wave, then the QRS, but then it takes longer and then longer and then longer to get there. And eventually it takes so long that the beat is dropped. So when it gradually lengthens in time, you have a second degree Mobitz type 1. They also call it a Wenckebach because it progressively prolonged. So when it starts to progressively get longer, you're like, oh boy, when is it going to drop a beat? And then you see that dropped beat, and then hopefully it picks back up. If not, you end up, doing CPR. All right. Second degree Mobitz type 2. Oh, I thought I took this monkey one out. I didn't really like this one. But basically, you're having some dropped beats because you might have like 2 or 3 P waves with no QRS, and then all of a sudden the QRS shows up. So I'm sorry, there's a ton of chaos going on right now. So basically these little monkeys are the PR interval, and they are trying to throw these coconuts, and here you can see these little P waves and then no beat. So the monkey is like trying to catch these and they're getting missed. So if you have P waves with no QRS, then it's a second degree. And then, this part right here, it says may progress to a complete heart block because you're having so many missed complexes. And then this PRI looks fine and this PRI looks fine, but you're just having all these missed complexes. So eventually your heart's going to give out and it can't compensate and you'll end up with complete heart block. But here's what the rhythm kind of looks like. So we're good. No QRS, and then we're good again. It's kind of like it's coming in between. Can you guys still hear me?
Yes.
Okay.
Yeah.
All right. Couple more minutes, guys. You're doing a great job hanging in there. I hope I'm not overwhelming you, but the good thing is that you can always go back and rewatch these little sections or need more explanation. And I'll have my open office hours tomorrow too. So if you let me know that you need to talk to me one-on-one, then I'm happy to do that for you as well. All right, so third degree heart block, I put this same picture in our heart block slideshow before, but I think that this one's really great. So what's happening in third degree heart block, they also call it complete heart block, is when the atria and the ventricles are not talking to each other at all. They're living completely different lives. In this picture, they're on a completely different roller coaster. So here's our QRS roller coaster. Okay, here is our P wave roller coaster. So here's all the little P waves, but they're each going completely randomly. We know that you should have one P for each QRS, but the P waves are just going along firing and the QRSs are just going along firing. And so the right atria is saying, is the track broken or something? And it's saying unable to deliver. And I thought that was pretty cute. It's a good way to show that there's no connection. So high risk of sudden cardiac death, we know that, but it's disassociation between the atria and the ventricles, which result in two separate rhythms that both show up on the EKG. So if you look at the P waves, there's one hidden right here. Okay, and then there's one here, and there's one here, and there's one here, and then you wouldn't be able to see it, but it would be hidden there and right there. Okay, so the atria or the atrial rate is regular. The ventricular rate is regular because they're evenly spaced, but they're not working together at all. They're on a completely different roller coaster, and it's coming off on the same EKG strip. All right. Right and left bundle branch block. I don't think you guys are going to have this type of a rhythm on there, but I wanted you to be exposed to it just in case that you do. It's a block that we haven't gone into at all, but the QRS is very, very wide, and the rhythm is typically regular. So if you see something like this, it is a block within the ventricles. So this is what causes the ventricular beat, right? The Purkinje fibers. So the Purkinje fibers are this is considered the bundle branch. So if there's a block really, really low in the heart conduction system down here, it is going to slow that ventricular conduction big time. So the QRS is going to be very wide. Look at it, it starts here, it ends here. It is super wide. If it is so extensively wide like that it's covering 5 and 6 of those large boxes, then you have a block down here, which is the bundle branches. Okay, it can be the right or the left bundle branch, depending on maybe someone had a heart attack and it injured this area right here. You're going to see a really wide ventricular. Hold on, guys. My family is so loud. I can hardly hear, so I'm going to go. Okay. All right. Just about done. Come on. But I want you to, if you see a rhythm, way. All right, we reviewed this a little bit, but this is the Einthoven's triangle. It's imaginary. It's just how the heart is being looked at based on how those electrodes are placed on the patient. So lead 2, which is normally how we read the heart, it's like if you're looking down from that patient's right leg and you're looking up at the heart and seeing the conduction that way. Lead 1 and lead 2 are from different angles. So if you were reading the EKG from lead 1, it's looking downward or a superior view. Lead 2 and 3 are both inferior views, but it's just how like science explains how those views of the heart are. All right, so I already told you typically you're going to read your rhythm in lead 2, whether it's on a telemetry strip or an EKG print off, which has all 12 views. All right, and that is what the EKG looks like up close. And I wanted to show you, so I put these arrows in here. Here's your little teeny tiny section of lead 2. Okay, and then here's all the other leads and it labels them. But typically at the bottom of the EKG is a long picture in lead 2. Okay, so you got to look at where it labels lead 2. But here's 1, 2, 3, AVR, AVL, AVF, and then V1 through V6. All right, and then I just, these are slides that you probably can just read to yourself, but basically I was showing you the three lead EKG placement is in the stoplight formation. So you want to remember that. The 5 lead EKG placement is what that little video was about. 12 lead EKG is resulting from 12 electrodes that are placed to gain 12 different views of the heart. And that's the one you guys have been most familiar with in terms of stickers and lead placement, but you're going to want to remember where those go. All right, the 15 lead EKG, basically, instead of putting them on the arms and the legs, they're putting them on the chest, and they're having the V1 through V6, and then they also put 3 electrodes on the back. And I don't see that done as commonly. All right, and then just some cute little pictures at the end. I want you guys to take your EKG practice test, take some notes, see where you're still lacking a little bit, and hopefully this was a little bit helpful. Review the sections that I went through if you need to. I'm going to upload this and try and put it in YouTube, but I'll also post the slideshow in Google Classroom. So do you have any questions right now? All right, I will stop this now and shoot me a message if you have any further questions, guys. Good luck on your practice test. You guys are all getting so close. So I'm excited to see what happens, see who can get those 80s. We will talk to you soon. Bye-bye.
Thank you. Bye.